Sireesha, we have over
It doesn't mean
200.
you have to be quiet. You just
Nice.
people
We can still talk and laugh.
Yeah, there are over 200 people registered.
Wow.
That's very exciting.
I know. I think you guys did a great job getting this out there.
You know, I think people have questions. Like, I think people are concerned. I think they have questions. I think, like, I got so many questions myself, like, and there were a lot of the same questions that you'd already received. But it's like, and you know, I think a lot of times people don't know where to ask them, or they may not have a doctor's appointment. So they like, who do I call? Where do I call? And then they're afraid of being put on hold. So I'm just assuming that that's what's happening. So this is very exciting. I'm so thankful to each one of you for being here and for the flashes of Dr. and President Rick Lange that we see.
Tell you what, I'd address better if I thought that the video would work. I'm gonna try on my Apple now.
Okay, because literally you're just flashing us. We're at 48 participants, and there'll be some questions that will pop up, and then there you go.
I didn't make it. Let me sign off. Leave the meeting there. Oh my, thank you for having me.
So, Kayla, you'll let us know when we start?
Yes, I'm gonna just get it on Facebook and then I will let you know.
Okay, perfect. I'm just really enjoying the artwork I'm seeing behind each one of you. There's like a beautiful piece of art over there with you, Dr. Lange, and then Dr. Reddy, you've got some stuff going on back there. I see some stuff over there. We all have like some kind of hobbies in our lives. What's going on there?
Yes, so we frequent, one of our faculty physicians has a gallery. And so he actually has world-renowned pieces for Mata Ortiz pottery. And he and his, actually his entire family, and the gallery's name is Flor de Barro. Barrio, right? Dr. Lange? Barro, I think.
Barro means clay.
Yes. And so, and it's on West Wind, and it's an incredible gallery. So if you haven't attended, you should go.
Well, my husband is Native American from the Pueblo of Laguna. And so those come actually from his Pueblo, from family members. And they've been in the family for hundreds of years. So yeah, so we are very fortunate to have, you see them over here, you see them over here, and there's some more over there that you can't see. But yeah, I've noticed that. So as soon as Kayla lets us know when we're live, I think we're live on Facebook now. Is that correct?
Yes.
Okay, do you want me to start?
Go for it.
Okay. Thank you all very much for being with us today. I want to especially thank our president of the YWCA board, Sharon Robinette. She has been so passionate about this topic, and it was her efforts and her diligence and her persistence. And for those of you that know her, Sharon's very persistent, and that got this COVID, question and answer part of our Imagine Health series actually to come up so quickly. So we know a lot of people have a lot of questions about COVID. They have a lot of questions about the vaccine and interactions. And so we've assembled quite a group of people. And so let me begin by introducing our moderator for the day or the evening, Dr. Sadhana Chheda. She's an assistant professor in the Division of Neonatology and Department of Pediatrics. But even more important than that, if there is, more important. She is a former board member of the YWCA. And as we say at the YWCA, you never ever leave. We don't let you. And so thank you so much, Sadhana, for agreeing to do this for us. We really appreciate it. We also have Dr. Glenn Fennelly. He's a professor and chair of the Department of Pediatrics at the Paul L. Foster School of Medicine and a pediatric infectious disease specialist. Thank you so much, Dr. Glenn Fennelly. We really appreciate it.
My pleasure.
In addition, we have just an amazing woman and Dr. Sireesha Reddy. She is a professor and chair of the Department of Obstetrics and Gynecology at the Paul Foster School of Medicine and Obstetrics and Gynecology and Pediatric and Adolescent Gynecology Specialist. Now, y'all try to say that twice, really, really fast. And finally, with us, we have Dr. Rick Lange, who always has this amazing smile on his face. He's the president of Texas Tech University Health Sciences Center in El Paso and the dean of the Paul Foster Medical School and a cardiologist specialist. I'm just wondering how all of you get all of these things on your white coats. You know, they just probably go all the way around. So I'd like to turn it over and welcome all of you that are with us today. I'd like to turn it over to Dr. Sadhana Chheda, who will be moderating this Facebook Live and this Imagine Health series by YWCA. Before we begin, before I turn it over, let me just remind everybody of the mission of YWCA. Our mission is to eliminate racism, empower women, and promote peace, justice, freedom, and dignity for all. So with that, I'll turn it over to our former board member, Dr. Sadhana Chheda. Thank you.
Oh, thank you, Sylvia. Thank you for that amazing introduction. And you're right. Once you're with the Y, you actually never leave it. And you have just been an amazing director. You've done amazing things for the Y. I have the honor of moderating this session. There are a lot of questions that we have compiled from the registrants. Some of them I'm going to keep open-ended. Some of them I will probably direct to different ones of you. So the very first question, I'm probably just going to direct this one to you, Dr. Lange. What are the vaccines in use in the United States?
Thank you. First of all, thanks for allowing us to participate. And we welcome the questions to make sure that we provide accurate information. In the United States right now, there are 2 vaccines that are approved. One is made from the Pfizer company, and the other one is from the Moderna company. But they're very similar. It's a new type of vaccine called a messenger RNA or an mRNA vaccine. So they have very similar types of vaccines. Probably the major differences relate not to how safe and effective they are, because they're incredibly safe and they're very effective, about 95% effective in preventing symptomatic COVID. And by the way, let me put it in perspective. If we've got a flu vaccine and it's 70% effective, we think we've hit a home run. So having vaccines that are 95% are it's really great news. Now, from our standpoint, they both require 2 doses. The Pfizer, the first and second dose are separated by 3 weeks. The Moderna, first and second dose by 4 weeks. And then again, from the medical standpoint, one of them requires it really be kept very cold till it's about to be administered. The other one can be kept in a freezer or fridge, but you all don't worry about that. That's from our standpoint. But those are the 2 that are currently available in the United States.
So you did touch on the safety and efficacy of these vaccines. Can one of you talk about who verifies that these vaccines are safe and effective?
So I'll take that, and I won't answer everything, I promise. No, but this is great. They go through 3 different phases, what's called a phase 1 study, a phase 2, and a phase 3. And there are more people enrolled. Phase 1 is you kind of establish the dose. Phase 2, you see whether it's effective. And then phase 3, you have thousands of people that you enroll in these trials to see whether it's safe and effective. And in both of these combined together, there were about 70,000 people in these trials. 35,000 got the vaccine and 35,000 got just a placebo. So that informs us that it's effective and it's safe, but then that's not it. Then afterwards, they continue to follow not thousands, but the millions of people that have already received the vaccine. So we already have safety data reporting after the first 2 million doses of Pfizer and the next 4 million doses of Moderna. So that's how we figure it out. So
Great, thank you. And you already touched on phase 1, 2, and 3, which was actually one of the questions. So that was great.
Oh.
Are there other vaccines in use?
Not currently in the US, but they're under development. And so you will hear, for example, an AstraZeneca vaccine. It's a little bit different. It's not an mRNA, it's a little bit different. There's a Johnson & Johnson vaccine. There's one that Russia has as well that won't be here, but will be available across the United States. So there are currently 8 other vaccines, or 8 total vaccines, that are used throughout the world. But in the United States, only 2, because we required that they be tested in the United States so we can check the data to make sure that it's very accurate. I'm going to turn over to Dr. Fennelly because he makes a good point, because one of the issues are, gosh, is it safe because they developed it so quickly? And I thought Dr. Fennelly had one of the best explanations that I've ever heard. Glenn, should we be concerned because, gosh, it just took 10 months to get these vaccines to market?
Yeah, thank you. Again, it's a fantastic question. And you know, as I've stated, the way I see this is built upon sort of decades of discovery. The messenger RNA compound alone, the various other components of the vaccine have been tested probably in animal models. There are probably assays looking at potential impact on, you know, accumulation, et cetera. So in that regard, that record was there. On top of that, the tens of thousands of study subjects, you know, the sort of safety studies begin with the phase 1 and 2. And each of these studies had sort of baked into them decisions at every point about go, no go. Are they safe? Are there any adverse events that would be expected in association with the vaccine or something even unexpected? So I think all of those goalposts were sort of hit along the way. And we know now through sort of post-marketing what some of the risks are in relation to allergy. We can sort of go deeper about that later on.
Great. Dr. Reddy, can you talk about the use of this vaccine in pregnant women? And then a follow-up question on that we did get was from people, what if I want to get pregnant? Would this affect my fertility? Can't hear you. We can't hear you. Dr. Reddy, we can't hear you. Okay.
You can hear me now, right?
Yes.
So thank you so much. I know that as women and part of the concerns about the COVID vaccine really were related to the fact that the vaccines were not studied in pregnant women. And this is for women and the concerns. So often we like studies to be comprehensive in a wide variety of populations to get a sense of if there's any differences in how we respond to different items, whether it's drugs or vaccines in general. So, so the issue with that raised a lot of controversy. So if the pregnant women weren't included in the studies, what does it mean for us? And so one has to go back to the original studies that were done, and we have to piecemeal some of the data to say, can it be safe in us? And that's really a decision that should be from the person who wants that vaccine, who's considering that vaccine, to get the information. And now we're starting to get accumulation of that information that I think that pregnant women can make a fairly safe decision, and a decision that would probably benefit them. One of the questions would be the 2 options. You get the COVID vaccine as soon as it's available, if you fall in the category right now, it's about prioritization. Second thing is wait for more information on about getting the vaccines in pregnancy. And so what is that more information that's coming out? Last year, there was a large study done, Dr. Lange just mentioned, phase 2, phase 3 clinical trials, and it was over 40,000 individuals. And in those 40,000, there were some pregnancies, incidental pregnancies. And we know when we compared the women who didn't get the COVID vaccine and to the women who did get the COVID vaccine, there weren't very many differences in the pregnancy outcomes. It was a small group that had incidental pregnancies, which was about 60 individuals. And so out of those 60, half are going to be, we don't know if we got the vaccine, and the other half, which were 30, got the vaccine. So in those 30 women, we know that there wasn't any significant outcome in the infant or the mom. The second piece of information is that often in these FDA trials and in these clinical trials, there's what we call DART studies too. They look for developmental and reproductive toxicity, and they do it in animals. In particularly in this one, it was done in rats, and both Pfizer and Moderna didn't show any significant outcomes. But there's only so much data that you can say in animals and compare it to humans. It could be, you can make a lot of arguments that maybe there's not that difference, but it is some evidence to say we didn't see any significant events in animals either. So that was the second piece of evidence that likely there wasn't. And now we're starting to see some of the other additional benefits of vaccines. We know that when we give vaccines like flu vaccine and we give something like Tdap vaccine, that often it's that initial response to that vaccine, which is the IgG antibodies that kind of pass through the placenta and get to the fetus, that it confers some protective immunity in the first few months of life. And some of that recent evidence, and which is actually hot off the press that you and I were sharing through the email, was this recent article in the Journal of American Medical Association. And interestingly enough, in a prior event that I did 1 week ago with Dr. Lange and Dr. Fennelly, I quoted a study which showed that maybe the antibodies didn't respond, and that was only over 60 women. But this current study in JAMA had over 1,500 women, and those women that did have COVID-19 disease actually showed both in the cord blood as well as in the infant that there were antibodies present that could at least help the fetus, the infant, in the first 2 months of life. So the other piece is really, how does, if you were pregnant and you did get the virus and you did have COVID-19 disease, what did that mean? And now we have some evidence showing likely that similar to another condition like the flu, although they're not the same, that even in COVID-19 affected women, that there's a little bit higher risk. In fact, that most of the women were more likely, 5 times more likely to have some kind of mechanical ventilation or even ICU admission to the hospital. So be on a ventilator versus those who weren't. So if you think about it, that if you were to know the statistics, that if you were to be pregnant and get COVID-19, you were 5 times more likely to have significant outcome. Would you make a decision to potentially get the vaccine? So that's a question I always ask, because that's important to have, like, how did women do during pregnancy? The second thing was preterm birth was more common. So now you're kind of not only thinking about the pregnant one, but how does it affect your infant as well? So the preterm issue was, and it's in some studies, it hasn't been shown. In a few studies now, we're starting to think, and more likely that it is more prevalent in the women who had COVID-19. And then lastly, I hate to say this, but really the mortality issue, that really pregnant women who had COVID-19 were more likely to die also, in addition, in comparison to their non-pregnant cohorts about the same age who got COVID-19. So we do know that pregnancy does confer some additional risk. So with that said, I think people, most of the organizations, the Society for Maternal Fetal Medicine, which is an organization for that supports high risk pregnancy conditions, or physicians who have fellowship in a high risk maternal conditions, has supported that pregnant women should get the COVID-19 vaccine. Before, they were on the fence that you should have a discussion, review the material, but now they have come forward and saying they support the fact that pregnant women should get COVID-19. The
So
American...
If I summarize, I can say that if you're a high risk woman and you're pregnant, you probably should get the vaccine, because getting the disease puts you at higher risk of mortality and morbidity, both for you and the baby.
Right, and you don't necessarily have to be high risk, meaning that that really the COVID-19 disease, certainly you get more severe disease if you have more risk factors. That's been shown, but the mortality is still high in those individuals who don't have high risk conditions too.
Yeah, no, I think I meant to say if you are in one of the priority groups and you
Yes.
have a high risk of getting the disease.
COVID, yes.
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 And then in terms of the fertility question, it looks like in animal studies, there is no issue. But can anybody answer, is there fertility issues in the male? Because that was actually also one of the questions.
I've not seen that at all as an issue. Dr. Fennelly, have you heard about
No,
that?
I have not either. And to the degree this could be looked at systematically in the animal models, it perhaps was. But again, I see it as a risk benefit overall. And again, the statistic that's right up there is now in El Paso, cumulatively, we're at more than 1 in 400 risk of death from COVID. Versus what we know about the side effects. So these side effects are 1,000-fold less common. Fertility issue is probably very conjectural. I don't predict there's going to be an issue. There has not been with any other vaccine that I can think of off the top of my head. So.
Right.
Well, Dr. Fennelly, can you speak to whether children should get the vaccine, and if so, which group and which population?
Certainly. So the overall goal of immunizing against anything in time will be herd immunity. What do we need to get there with COVID? We may need as high as 80% or higher to have the entire population immunized. If we exclude children, we're excluding maybe 20 to 25% of the population, depending on the city, the municipality, the county. So yes, there's a strong rationale from the point of view or the perspective of herd immunity. Number two, children are at risk, even though they're much less likely to get severely ill or hospitalized from COVID. Cumulatively, we've had more deaths from COVID than the worst seasonal flu-related deaths in children, over 180. Also, there is a syndrome called MIS-C, which is very, very rare. It accounts for less than 1 in maybe 10,000 children that get COVID, but it can be lethal. Already there have been 26 deaths reported due to that, and well over 1,600 cases in the United States, which often results in hospitalization, and it's life-threatening, and at very least it puts the child in the hospital for many days. So putting all of that together, yes, there's a strong rationale. We're not there yet in terms of knowing enough about safety and effectiveness. So all of the studies we've talked about thus far, the phase 1, 2, and 3, will have to be reiterated in children. We'll have to decide what is the optimal dose. And in that a 2-year-old will probably need some dose adjustment relative to a 20-year-old. And what sort of outcomes will be looked at in those studies? It's unlikely that you're going to be able to get enough data to show this protects against hospitalization, we could probably get to a point where we know that it prevents infection and in time prevents transmission. So those studies are ongoing down to age 12 with both the Moderna and the Pfizer vaccines in the US.
Great, you anticipated one of my questions in terms of what trials were going on with children. And can you speak briefly on why the current age limit is 16 for children to get the vaccine?
Right, I mean, simply stated, number one, the priority was to target older teenagers and adults because we know that with increasing age, the risk of severe disease or death from COVID goes up very, very rapidly. And we have data showing safety, efficacy, reliable dosing, 16 and over. So there are many, if you will, 16-year-olds, 17-year-olds and beyond in El Paso that have been immunized that have underlying comorbidities.
So if someone has a 16-year-old child with diabetes, that definitely fits the criteria to get the vaccine, correct?
Correct.
Okay, great, thank you. So who should not get the vaccine since you've talked about 80% herd immunity?
Let me at least address one part. There are very rare circumstances where people can have a very severe allergic reaction. We call it anaphylaxis, or some people will call it shock. It's so rare, it happens about 3 to 5 times out of every million doses given. So, but since this is 2 doses, if someone has had an anaphylactic reaction with the first dose, they shouldn't get the second dose. And I think the recommendations from the CDC are pretty clear about that.
So on that same note, Dr. Lange, we got some questions about people who are allergic to nuts and seafood. Should they still get the vaccine?
Yes. We'll talk more about
Should people pre-medicate with Benadryl and steroids before they get the vaccine or Tylenol? Those are other questions we've gotten.
Great questions. No, this is such a rare event because many of us, if we look around, have allergies to a variety of things, to some antibiotics and medications and different foods and even seasonal stuff, is that we would all be taking Benadryl, we'd all be taking steroids. And first of all, very few of us would need it. And we don't want to do anything that would interfere with the immune response. So the recommendations are not to do that. But if someone's had an allergic reaction, they should alert their people immunizing them because those severe allergic reactions typically take place in the first 15 minutes. So you'll notice that every time we give a vaccine here or at any of the centers, we always watch people for 15 minutes. We'll extend that to 30 minutes if someone has had a severe allergic reaction to antibiotics or to something else. But it's not a contraindication. It should not deter somebody from getting the vaccine.
Okay, another question on a specific group. If you're breastfeeding and you fit one of the priority groups, should you get the vaccine? If you get the vaccine, should you pump and dump?
This looks like a great question for our pediatrician or our obstetrician. Not for the cardiologist. Go ahead.
So there's actually absolutely no biological plausible reason not to breastfeed. And we do it even in active COVID-19 disease. And it's all about following all of the hand washing, hygiene, masking techniques. And also in the setting after the vaccine, there's absolutely no biological plausible reason not to breastfeed. In fact, we do know that some of the protective antibodies can be passed along in the breast milk. So it's important to continue breastfeeding even after receiving the vaccine.
Sadhana, may I jump in here for a second because it brings up a good point. You cannot get a COVID infection from this vaccine. It is not possible because this vaccine doesn't contain any viral parts at all. So for everybody listening, and people say, well, gosh, I wonder if I could get COVID infection from this vaccine. The answer is an emphatic no, no way.
Sadhana, I'm just going to jump in just to clear some of the questions that have been popping up. We have a lot ongoing that might pertain to some of what we were just talking about. Dr. Lange, you talked about allergy medicine. What about pain relief medications? or other, fever reduction medicines prior to taking the vaccine or after?
Yeah, so the current recommendations are not to pre-medicate with anything. Obviously, if you have other medications that you routinely take, please take them. You're not supposed to stop any routine medications. But in terms of pre-medicating in advance, because you might think you might have an allergic reaction, it's not beneficial. Now, afterwards, if you do happen to have some fevers or chills or some muscle aches or joint aches, we're recommending some Motrin or Tylenol, but afterwards, in case you need it, but not beforehand. Great question.
And then Dr. Reddy, there was one that I think would be great for you, or Dr. Fennelly. If there are any known vaccine, drug, and medication interactions that could reduce the efficacy of the vaccine, especially for pregnant women or children?
I would say, I think a couple of them have been addressed already. Something, it's, I guess, more theoretical than real, but something like ibuprofen or Motrin could conceivably interfere with sort of the inflammatory response. Certainly pre-medicating with steroids or somebody on steroids, there may be less than optimal immune response. So that could become an issue for somebody who's on chronic steroids. Short of that, there are no known interactions.
Actually, I specifically, Dr. Chheda had mentioned this to me, and as we've just talked about, there doesn't seem to be, but there have been a few studies about looking at, the non-steroidal anti-inflammatories, and they actually showed a lot of different kinds of results based on the type of vaccine that was given. So we really don't know. But one of the conclusions from that study was really perhaps you shouldn't, or there is no need to prophylax. Don't do it before the vaccine, because there may be some reduction depending on the vaccine used. But definitely afterwards, as Dr. Lange and Dr. Fennelly mentioned, if you have side effects, if you have a little bit of a fever or myalgia and you need to take it, you should take it.
And one last one along the same lines, if somebody is immune compromised or on immunosuppression medication, does the vaccine pose a risk?
Yeah, going back to Dr. Lange's point about the fact that this is not a live vaccine, I think there might be somewhat of a misconception out there. HIV or AIDS, certainly, we can't use live vaccines like measles, some of the forms of flu vaccine that have been available over the years. The live polio vaccines were contraindicated. But this is a non-replicating, the mRNA just makes the protein and then it's gone. The concern would be more in the direction, is that individual effectively immunized in terms of maybe a less than sufficient immune response? This is another reason we need to get towards optimizing herd immunity to help protect the individuals that may be more vulnerable.
So one of the other questions we got, and it refers to something that Dr. Lange mentioned, 21 days for Pfizer, 28 days for Moderna. Do you have to get it at those time points? What would they still be effective if you get them a little bit later?
In fact, great questions. Originally, when they came out, they said, take it with plus or minus 4 days, either 4 days earlier or 4 days later. But now the recommendations are to extend it out to 6 weeks. That is, once you get your first dose, if for some reason you can't get the second dose, let's say you're not in the same place geographically where you got it, or it wasn't available at that particular time, or there was some other condition, they're recommending that you get it within that 6 week period. And the thought is that it will be just as effective then. Now, after 6 weeks, we just don't have enough data. So we're really trying to reinforce that. If you plan to get it, plan to get your second dose within the next 6 weeks.
So we had one of the travel nurses who came out to help when things were really bad in El Paso. He got his Moderna vaccine over here, and he was obviously going somewhere else after that. And his question was, can I get the Pfizer as a second dose? Do I have to get the Moderna?
Wow, really great questions. If at all possible, they're recommending that you get the same medication. Now, there'll be an occasional instance, and I can think of two, for example. One is where you got the dose and we give you a vaccination card, but you lost it and you just can't find it. You don't know what you got. Their recommendation is that you still get a booster dose, even if it may not be the same thing. And then again, the other option, or the other thing that may happen is that, Sadhana, is that you get your first dose and then you can no longer don't have access to that medication for whatever reason. They're recommending that the second dose be the other medication. But again, it's not a routine practice. This is, if in other words, it's more important to get the second dose, even if it's a different medication, than not to get it at all.
So we have another question on the vaccination in terms of the current variants and the mutations. Will they be effective against these mutations?
Dr. Fennelly, you want to take that?
Yeah, this is a fantastic question, and I think a question that's very, very prevalent now. So the emergence of these variants in time, these are RNA viruses similar to the RNA that's injected, and when they replicate, they are, if you will, sloppy. So this is not unanticipated. There's going to be some selection for variants that are, on the one hand, maybe more contagious and perhaps more virulent. So these have arisen in the UK, South Africa, Brazil. They can also arise in the US unrelated to being imported, similar variants. There is evidence, number one, that they are more contagious, possibly more lethal. The good news is, for the most part, with the Moderna and Pfizer, these appear to have good effectiveness against the UK variant and to a degree against the South African variant, although the final data is not in as of yet. Where are we going with this? The important thing to note that the quicker we get the majority of people immunized here in the US, the less likely these variants are either going to arise de novo in the US or be transmitted if they arise or they're introduced. The second point is that I think as long as the majority of us have some priming against this or some immune memory, there is going to be some effect, and it may prevent severe disease. It may not prevent transmission. Finally, I think the vaccine producers, particularly Moderna, has said that it's really already on this. They are already designing a vaccine that should cover against the variant, and they're planning studies where they'll ask the question, is there a need for a boost, number one, and a need with the boost of the existing variant or the wild type variant versus those sort of escape variants? So that data could be available very, very quickly, just taking a subset of people that were already immunized in the same studies 8 months ago and boosting them with one or the other and seeing how well their blood will neutralize the wild type versus the variant in a Petri dish.
So that, Dr. Fennelly, leads into a question we also got in terms of what is known about getting a repeat dose like the flu vaccine.
Right.
Are people going to need to get additional doses?
Yeah, I think the short answer is the prediction is yes, we will. There's going to be seasonal variation. Back to Dr. Lange's point up top, if the Moderna or Pfizer vaccines were flu vaccines, this would be an absolute home run hit. To have this incredible reduction in mortality, the seasonal flu vaccines just don't work that well, if you will. Part of that is the way they're designed. Some of them are passaged through chick embryos, some are done in tissue culture. It's hard to match the prevailing flu, and the technology just in a way is not what the Moderna or Pfizer are or some of the other coming vaccines. So yes, I think we're looking at a future where we get primed this season, we have good immunity against the prevailing strains now, and then some sort of boost either to get our antibody back up to where it needs to be or to make new antibody that can recognize the new strains is going to be necessary going forward. And maybe it'll plug into the traditional fall immunization against the flu. So we will have
that leads up to another very quick question I'm going to ask. But before I ask that question, I'm going to, after this question, ask some questions on whether you got the infection and vaccination. So now, Dr. Fennelly, if I am due to get a Tdap shot and I'm supposed to get my COVID shot, should I get both vaccinations at the same time or not?
No, think of the sort of crucial window is 14 days before or after, if you can coordinate that. So it's not a strong absolute contraindication, but there is some evidence that the Tdap vaccine, for example, if you get it within a week, it could potentially interfere with a new vaccine or a new antigen. Same goes if you get the Moderna or Pfizer or another vaccine and then get that may interfere with the effectiveness of vaccine you get within 2 weeks after that. So a window is 14 days before or 14 days after. You should not be immunized with other vaccines.
So I'm glad you mentioned that, because I saw a patient this week. As you know, we're vaccinating. We gave her the first dose, and then she got a flu vaccine 2 weeks later, and then came back for her next dose. And I had to say, oh my gosh, we got to wait until you complete that. So anybody that's listening, as Dr. Fennelly said, don't get anything 2 weeks beforehand. Don't get anything between the doses, and then wait for 2 weeks after.
Okay, so if you have COVID, should you get the vaccine? If you get COVID between your first and second dose, should you get the second vaccine? Who's going to take that?
I'll take it, and then I'll see if other people are doing. If you get, first of all, you ask about reasons you shouldn't get vaccinated. We mentioned one, if you have anaphylaxis. The other is if you have active COVID infection, you shouldn't. So if you get a vaccination and you get COVID infection, you probably shouldn't get the second dose at that time. Now, what about someone that's had a COVID infection? Well, we know that those individuals have antibodies that last for a long time, probably 3 to 5 months. So the CDC is still recommending that they get vaccinated, because you develop more antibodies with the vaccine than you do with your own infection. But it seems evidence would suggest that if you get it too soon after you've recovered, you may be more likely to have the fevers and chills, and they may be a little bit more severe. So I'd be interested in hearing what Dr. Fennelly or what Dr. Reddy. I'm telling my patients that have COVID, you have antibodies to protect you for 2 or 3 months. Let's wait for them to give you the vaccine. But we could give it, but you just may have a little bit more severe reaction. There was a study that just came out today that suggested that's the case. So you can look at the COVID as being your first way to make antibodies, and then your vaccine is your booster after that. So Glenn, what are you recommending? Are you recommending?
Yeah, no, I would agree with that. And I think the other scenario that has actually come up, since we have, I think, been relatively fortunate in El Paso to have access to some of the monoclonal antibody treatments. What if an individual gets that treatment? The guidance there is to wait for 90 days, which is counter to the 6 weeks that we talk about. So let's say you get one dose, you develop COVID a week or two later, and you get the monoclonal antibody, it's 90 days, and that theoretically it could interfere. So that it's very interesting what you point out about the individuals that have had COVID infection. The more proximal you are, the more side effects you get. So yeah, but I think 90 days is probably the longest you should wait after having acute COVID, based on what we know.
So one of the fun questions we got, actually, I thought this was really interesting question that I actually had never thought about. How long after the second dose can I get a beer?
Well, you probably shouldn't do it without your doctor. I mean, I'd say take your doctor with you, because they can make sure it's safe during that time period. Sadhana, you meant, I had a beer distributor I vaccinated, and he said the same thing. And my recommendation was, I said, wait for 48 hours. And the reason for that is, if someone develops these headaches or nausea or vomiting or fevers or chills, it usually happens in the first 48 hours. So you don't want to be miserable and then throw a beer on top of that. So I told them to wait for 48 hours, but I did tell them to call me, okay, so I could help them after that.
So We've got this question from people at the Early Childhood Intervention Services. So they used to go out and do a lot of visits in person, OT-PT speech, and now they're doing a lot of telehealth visits. So their question is how, if they get vaccinated, can they go back to in-house visits, or should they only go back if the families are also vaccinated? And Dr. Reddy, we also got questions in terms of high-risk visits for OB in terms of can you do it in person? And is it safer if you've been vaccinated?
So I can answer the question about the high-risk visits. The issue is, and Dr. Fennelly can discuss this as well, but even after the vaccine, you know, there is this still potential of harboring the virus and still passing the virus. So it's still important for us to continue, even after the receiving the vaccine, to continue to follow all of the protocols that we normally do. So I think that data about whether we harbor it less, you know, whether the transmission is less, we don't really know that data quite yet. So at least for right now, I think people still need to follow the rules, even if they've gotten the vaccine or received the vaccine. So whether we continue to have we have continued in the office to see our high-risk obstetrical patients and also any obstetrical patient, but we follow the routine guidelines as we do with everything else. Yes, you know, if a patient feels extremely anxious and they're high risk and they don't want to come to the office, could we do some visits, you know, as a telemedicine visit? Absolutely, we can do that for items like reviewing results, but things such as getting an ultrasound, making sure you get your routine health care, which is really important in this process, not to ignore the routine health care, and as well continue to follow some of these processes where, you know, we know it reduces transmission, is important to continue to do that. So, you know, the COVID-19 vaccine helps us and assists us. Obviously, the efficacy is fantastic for us not to get to minimize the disease, but transmitting is still possible. So you need to still follow some of those protocols.
Dr. Fennelly, can you answer the question for the ECI people?
Absolutely. So, you know, again, to echo what Dr. Reddy said up top, we as healthcare providers, now that we're immunized, we're protected. We know we're likely protected against severe disease, the need for hospitalization and death, fortunately. On the other hand, it's the unknown still is, can we transmit it to others? And if we're exposed, can we get infected? We don't know, and with the new variants on the horizon, we know even less. On the other hand, I think this segues with the question about back to school. You know, what are the risks, benefits of continuing, whether it's a virtual medical visit for children with special needs, whether it's classroom education versus virtual for a child with special needs. We have enough evidence now to show that if we follow the rules in terms of masking, distancing, if we cohort the children in schools, even in the absence of routine testing, the rates of transmission in K-12 populations in certain instances may be below that in the general population or the risk in certain homes. But I think we're there now, even in the absence. The thorny issue will become many states are not vaccinating teachers, not making it as much of a priority as other states. Ideally, we want the educators and teachers to have that same sense of safety that first line healthcare providers have had. So that's where we are with that.
A great answer, and you're right, that is a big anxiety for a lot of people with back to school and teaching. We did earlier have a really interesting question from someone who is a routine donor for blood and plasma, and that person asked, can I donate blood after I've had the vaccine? can I give plasma for antibodies after I've had both doses?
So there is no restriction in donating blood after you've had the vaccine. Dr. Fennelly, you can clarify that, or Dr. Lange, but I have not seen any restrictions on that. So in fact, you don't have to even go get testing. It's not recommended at the prior to going and donating blood, because most of the blood will get tested at that point. But as far as after the vaccine, no.
Yeah, and I would add to that. I mean, if the consideration is post-vaccination, is that serum effective in terms of passive immunity, if you want to donate that blood for therapeutic, the same way convalescent serum has been used? I think that's still unknown, and there may be differences in the quality of the antibody that is induced by a natural COVID infection versus the vaccine. In time, I think we're going to find it may be equally effective, but I think that will have to be studied first. So that would not be a reason to go donate blood. And to whoever asked the question, thank you for your ongoing donation. I think that's fantastic.
So back to the earlier comments you made about visits to the doctor, somebody just asked a question, which they're saying, knowing that hospitals are sites of transmission for COVID-19, should I delay seeking treatment until I am vaccinated?
Can I take that one, Sadhana?
Yes.
And that's because I actually believe the safest place in all of El Paso is our hospital and our clinics. And why do we say that? Because there's obviously screening done. We don't allow visitors in generally. Everybody there is wearing masks, and in COVID areas, if someone has a COVID infection or suspected, they're in specific isolated spots of the hospital where everybody wears protective equipment and N95, and everybody washes their hands. It really is. People don't spread COVID in the infection in the hospital. They come into the hospital with it. So we actually say that the safest place in all of El Paso is the hospital and our clinics. Now, by the way, Sadhana, as you know, and Dr. Fennelly and Dr. Reddy know as well, we actually monitor how many COVID cases we have among our entire campus. And 99.5% of those cases came into campus. They weren't spread here on campus. So please don't delay your care. If you need care, from a cardiology standpoint, since the COVID infection, more people have died of heart attacks, more people have died of strokes, more people have died of cancer that wasn't detected, more people have died of infection, more people have died of lung disease because they're not coming to the hospital early enough or they're not receiving their care. So please don't, anybody that's listening, please don't delay your care for concern. You will receive excellent and safe care at any of the hospitals.
So there is a vaccine registration, which is the vSafe program by the CDC. And somebody asked, is there any plans in making that data public regarding side effects to the vaccine?
I can't speak. I'm trying to think. They certainly use that data to inform us already. For example, we talked about anaphylactic reactions. That wasn't discovered in the phase 3 trials. That was discovered as a result of the vSafe. How publicly available is all that information? I don't know the answer to that. So I don't know, Glenn, if you know that. But that again is meant to inform us about side effects. Glenn, what are your?
No, I think the example you just pointed out is an example of how it is being made public. I mean, that took the form of a CDC MMWR report for I think both the Pfizer and the Moderna vaccine, with a matter of 2 weeks after that data was accumulated. So absolutely, I think that's the impetus behind that. So I encourage all of you that are vaccinated, please, to sign up for that.
So do people pay for this vaccination?
No, the vaccine is free. Now, some of you say, well, wait a minute. They took my insurance information. What was that about? The places that administer it can charge your insurance for just the administration fee. It's usually $17 or $24. You don't pay that, by the way. It is absolutely free to everybody in El Paso. So don't let that be a deterrent. So that's the short answer to that.
Thank you. I am going to just talk a little bit about the vaccine distribution. This panel is not meant to talk about vaccine distribution, but we did get some questions about that. I did get a response from UMC, so I will kind of just reiterate what that response is. Basically, UMC and the city are the only hub sites that are designated by the state to get people vaccinated. The city has registration processes where people get on a wait list. UMC opens weekly based on the number of vaccines they get, and the people who are able to register get the vaccine within 5 to 7 days. It is then opened once again when they know how many vaccines are being shipped. They're going to be working with their clinics on the west side and Fabens to target patients over a certain age to help vaccinate the most vulnerable. They also have a mobile unit that was purchased by the county to be used by UMC. They say they're looking at getting that up and evaluating that sometime in late February. We did have a question about seniors who are not internet savvy or have no internet. And the response I got is there is a number they can call. It's 915-975-8901, and Kayla will have that up somewhere. This helps those with no internet access, but from what we understand, it is difficult to get on, and they just encourage people to keep trying. Dr. Lange, can you add anything to that? And I know this is not a totally fair question.
No, it's fine. Let me describe the process for a second. The federal government distributes it to the state, and the state gives it to the individual cities with very short notice. For example, they'll tell us at the end of 1 week what we expect. And a number of us have requested vaccines, but it's really at the mercy of the state about who gets it. The two major sites will always get it, the Department of Public Health and UMC, and the rest of us, it just depends upon what the state gives us allocations. For example, we have a request for several thousand doses. We've already given 4,000, but the state has given it to other areas. I do understand the frustration. You think, well, why couldn't there be some central registration? The state doesn't allow it. It allows, by the way, if a vaccine is delivered to a certain center, it has to be delivered by that center. They have to have their own website. They have to have their own registration. And that's why everybody's saying, well, why do I have to register at 3 or 4 different sites? And that's just because that's what the state has mandated at this particular point. The city is now getting about in the neighborhood of 10 to 15,000 doses per week. With additional manufacturing by Pfizer and Moderna, the plans are to increase that substantially, probably by the end of May and by the end of June. They each say they'll have 200 million doses available. So my message to everybody there is stay with it. We're really targeting, first of all, the healthcare providers. We have all those, people over the age of 65, and those between 16 and 65 that have a serious medical condition. Those are the groups that we're targeting now. Once we get those, then we're going to move to do all the teachers, for example, and all the frontline individuals working in food industry, for example, as well. So, Sadhana, does that address, you think, the major issues? Other things?
I think so. Thank you so much. And Kayla has popped up to let us know if there's any more questions that we have forgotten to address to you all.
Leftover questions. This one's a little bit specific, but is it safe to get the vaccine with Prolia shot? Is that the same answer as any other? If you were getting your flu shot, you would wait 2 weeks, or because it's a little different? I don't know if that's.
Dr. Fennelly?
Oh, he's Googling.
Prolia is a particular type of medication that's an antibody against osteoclast receptor. It's used for women who have osteoporosis. Actually, not just women, but in general, it's a treatment for osteoporosis. So, I certainly think that certainly waiting, there's no exact recommendations on, after COVID-19, whether or not to receive Prolia. Prolia, if you've been ongoing and you've been getting it and you haven't had any side effects, I would probably say wait 14 days. I have not seen the recommendation to delay the injection, but that's probably something we could work on looking at a little bit better. I can't see any reason why you would delay it, but I think in general, waiting 14 days before or after to ensure side effects aren't related to the Prolia versus the vaccine would be important. So at the least, waiting for a few weeks to ensure. But there is no recommendation on their site. I've had a few people ask me that, in particular, since the type of medication it is, I can see why you're asking that particular question. At the least, wait for a few weeks, but there's no exact recommendation from the manufacturer.
And then are the contents in the first dose of the vaccine the same as they are in the second dose?
It is exactly the same. It's the same dose and the same volume amount as well. Great question, Kayla.
And I think this is a good one to kind of wrap up with. How can everyone stay up to date on vaccine information, protocols, safety, et cetera?
That's a great question. For many of us, cdc.gov is a great resource. And that's readily available. There's virtually no restriction. You don't have to be a physician. You could easily access it. And that's actually what somebody else was asking about, how to get the latest information, published information. That's where you would get it. And it's updated on a daily basis. So the cdc.gov is probably one of the best sites.
And Sireesha, all of us, I say Dr. Fennelly, Dr. Chheda as well, we all think it's reliable. I mean, CDC really vets their stuff. So as any place you can take it to the bank.
There is, Texas Tech also has information. Isn't that correct, Dr. Fennelly and Dr. Lange?
There is. We have a website and we try to post latest information as well, and a variety of different things. So feel free to access our website as well. But I would say that I'm at the CDC site probably 2 or 3 times a week just to make sure that we're up to date with everything as well, providing accurate information.
So someone did ask about the homebound. Have they been considered? And I know that UMC did tell me they were working with some entities that deal with the elderly that do not have access to internet or family. And I don't know much more than that. I don't know if any one of you actually knows more on that topic.
You know, most of the homebound, either at long-term care facilities or nursing homes, CVS and Walgreens actually has a contract with the federal government to meet those needs. You all may be aware that we were at a home recently with individuals with disabilities that couldn't get out to vaccinate them. But the long-term plan is actually have the pharmacies reach out to these individuals.
Great, thank you. Kayla, did you want to say anything?
Just thank you everyone for joining, and the panelists as well. Thank you for very helpful information. And just if you can stay on for just a second so I can take a picture in a minute. I just always forget to do that at the beginning. So I just want to grab you really quickly before that.
Well, before you log everybody off, Kayla, can I just summarize based on what everybody just said today, that if you are entitled to take the vaccine, take the vaccine. If you're pregnant, take the vaccine. If you're breastfeeding, take the vaccine. If you're 16 years old and older and have a pre-existing condition, take the vaccine. There are very few reasons not to take the vaccine.
Perfect. And if the panelists can just look at their cameras and smile really quick. Thank you so much.
Thank you so much, Dr. Lange, Dr. Fennelly, Dr. Reddy. I really appreciate you guys doing this panel.
Dr. Chheda, you're a great moderator. Dr. Sylvia Costa, thank you for allowing us to participate. The YWCA does tremendous things throughout the community. So it's a privilege to partner with you and to provide this information. So thank you.
Thank you, everyone.
Thank you.
Good night.
Good night.
Good night.